So first I'll call upon Dr. Sameeksha to come and give her talk on the basics of flaps and grafts. Yours is this, no? Yeah, I'll remove this.
Good morning to everyone present here. I'm thankful to Rituja and the team to give me this opportunity to speak. I will be starting off this IC with some basics of flaps and grafts. To begin with, I will talk about the relevant anatomy. Externally, the eyelid, the horizontal palpebral fissure is about 27 to 30 millimeters, while the vertical is about 8 to 11 millimeters. The medial canthal angle is about 45 degrees, and the lateral canthal angle is about 60 degrees. The lateral canthus is typically about 1 to 2 millimeters above the medial canthus. When it comes to the cross section of the eyelid, we can notice that it is made up of three main layers that we should be aware of. That is the outer skin, the inner mucous membrane, and a semi-rigid skeleton in between, which is mainly composed of the tarsus in the upper and lower lid. Functionally and anatomically, the eyelid is divided into two lamellae. The anterior lamella comprises of the skin and the orbicularis along with the eyelashes, and the posterior lamella comprises of the mucous, conjunctiva, the tarsus, the retractors, and it is divided from the anterior lamella by the gray line. The muscles that we should be aware of while reconstructing with flaps in this area are the orbicularis oculi, which is a superficial subcutaneous muscle, and the levator palpebrae superioris, which is basically in the form of an aponeurosis that inserts onto the tarsus, mainly in the upper lid. So the skeleton of the eyelid is mainly formed by the tarsus. In the upper lid, it measures about 8 to 10 millimeters and in maximum height, and in the lower lid it's about 3 to 5 millimeters. Both the upper and the lower tarsus gives rise to the upper and lower crura of the medial canthal tendon and the lateral canthal tendon, which go on to insert onto the orbital wall on the medial and lateral side respectively. It is important to know that the blood supply of the eyelid is very extensive. So the grafts and flaps in this area survive very well, and they are quite aesthetic in this area. So it makes reconstruction a little bit easier in this area. It is important to remember these relaxed skin tension lines that were proposed by Arthur Borges. Basically, when we place incisions along these lines, the scar is more aesthetic, more hidden, there's lesser gaping, and better results long term. When it comes to principles, the assessment of the defect is the most important thing that we do initially. We should be knowing whether it is a full thickness or a partial thickness defect, whether it's involving the lid margin or not, the amount of lamellar loss, each lamellar loss, the location, whether it's medial, lateral, or central, whether there is any canthal involvement, whether there is any canthal tendon involvement, whether there is lacrimal drainage system involvement, and age of the patient and laxity of the eyelids is important to decide which kind of reconstruction we want to take up, and including the condition of the opposite eyelid and mobility of surrounding tissues. So when we reconstruct, we have to remember to reconstruct each of these layers that we talked about, that is the skin, the skeleton, and the mucous membrane. Since we functionally divided it into the anterior and posterior lamella, each lamella has to be reconstructed either together or separately. It's important to know that one layer has to carry its own blood supply, so it has to be a flap, and the other can be a free graft. When we reconstruct, we should know that we should maintain a proper lid margin contour. It should conform completely to the curvature of the globe. Incisions and lines should be parallel to, as far as possible, to the relaxed skin tension lines. We should maintain anchorage to the bony orbit in the form of the ligaments that we talked about. The horizontal size of the defect is usually determined by bringing the medial and the lateral edges of the defect a little bit closer under some tension. The LPS and the inferior retractors should be inserted where possible. And lacrimal drainage reconstruction may be either primary or secondary, depending on the defect and the extent of injury. It's very important to know that we should be aiming for symmetry between two eyes. So the options for reconstruction in this area are mainly flaps and grafts. The major difference between flaps and grafts is that flaps are tissues that carry their own blood supply. Grafts are tissues that are severed from their original blood supply. So the flaps rely on growth of new blood vessels also, but they primarily carry their own blood supply. In the area of the ocular region, they give a very good color and texture match. And the facial flaps, usually the main blood supply is from the muscles, so they don't really require to be based on any particular vascular pattern. They may be classified depending on the composition, on the vascular pattern, and their location. So these are some of the types of flaps that can be used in the periocular area. This is an advancement flap where it is detached on 3 sides from its surrounding tissue and advanced into the defect. VY-plasty is also an example of it. A transposition flap where there's an intervening tissue and the tissue is mobilized, like the upper lid tissue is mobilized into the defect. Or there are sliding flaps where it is detached completely from the surrounding tissue, but it still maintains connection to the underlying muscle, and it's slid into the defect and closed. There are rotation flaps in which the adjacent tissue is rotated into the area of the defect. This is a rhomboid flap which is rotated into the defect, and a bilobe flap. Interpolated flaps also have intervening tissue that is present, and it is used to cover the defect. Island flaps are those which are completely dissociated from the surrounding tissues, and they only maintain blood supply through the underside of the flap. Grafts. Now, grafts are tissues that are mobilized without preservation of original blood supply, so they completely rely on the recipient site vascularity for their survival. The types that are used usually in eyelid reconstruction are skin grafts, and usually full thickness skin grafts, cartilaginous grafts, or mucosal grafts. Sometimes when we're reconstructing an entire lamella, we might require composite grafts. So when it comes to options for reconstruction, the anterior lamella is usually reconstructed with a full thickness skin graft. The kind of areas that give a good color and texture match are post-auricular area, the medial upper arm area, the groin area in children, upper eyelid, or a contralateral eyelid. Flaps that can be used in these areas are Tenzel's flap, cheek rotation flap, glabular flap, trippier, and a Fricker flap. When it comes to the posterior lamella, it mainly is comprised of the tarsus and the mucosa. So it can be reconstructed with the nasal septal mucosa, the palatal graft, the oral or cheek or lip mucosa graft, conjunctival graft, and tarsoconjunctival graft. When it comes to the flaps, the Hughes tarsoconjunctival flap is a very popular method of reconstruction. When it comes to reconstructing both the anterior and posterior lamella, free grafts will not work, as one layer needs to carry its own blood supply. When it comes to flaps, the Cutler-Beer procedure is a very commonly performed procedure, and so is the mustard lid switch flap. The details of these will be discussed in further talks. So when it comes to small defects, direct closure may be possible. In case of young individuals, if there's a 25% defect, in case of older individuals, up to 30% defects can be closed directly. It can be helped with a lateral cantholysis or with a semicircular flap. Moderate sized defects will require a lid switch flap or a Cutler-Beard reconstruction. Cutler-Beard is a basically lower lid, full thickness transposition flap. Large size defects will require a Cutler-Beard reconstruction, or they can anterior and posterior lamellae can be reconstructed separately with the options available. When it comes to the lower lid, usually the anterior and posterior lamella are reconstructed separately with the available options. There are other methods which help mobilize the surrounding tissues and make it easier for closure, because at the end of the day, there shouldn't be any tension at the suture lines. So to summarize, we went through the relevant anatomy of the eyelid, assessment of the defects, principles of reconstruction, and options for reconstruction. At the end of the day, we must remember that treatment has to be individualized to the patient, so the assessment and proper planning is very important. Thank you so much for this opportunity.
Excellent. Thank you, Dr. Sameeksha. And that was really nicely and very simply elucidated. And just a couple of things that I'd like to ask you. Sure. You mentioned about repairing for the lacrimal reconstruction primarily or secondarily. So how do you decide whether to go ahead in the first when you directly see the patient? Or
So if it is usually due to trauma, finding the lacrimal system itself becomes very difficult, and depending on how soon after trauma they've presented to you, if there's a lot of swelling, it is difficult to find the lacrimal system at all in the first place. But if it is a planned surgery, then it can be done simultaneously.
right. And I'd like to ask Dr. Grover as well. So, when you have a tumor, do you prefer measuring the margins in the OPD to decide what kind of surgery you would plan, or do you decide on table?
See, first of all, you have to have a plan in the mind when you see the tumor and you know the extent of dissection that you're going to do, that you have plan A and a plan B in mind. And on the table, you often have to modify it. But you really have to have a plan thought out with your decision having been made to an extent before you start it.
And where do you generally most commonly take skin grafts from, free skin grafts?
So medial upper arm is a very easy place to access, easy to close primarily, and it gives a very good match to the eyelid. So
That's your preferred?
yeah, that's my preferred site.
Okay. Thank you, Dr. Sameeksha.
Partial thickness grafts.
Partial-
What about the full thickness ones?
Full thickness ones also I tend to take from the upper lid, and sometimes the post-auricular. I don't like to go for anywhere else. It's just
Yeah, I would like to ask whether you have used any other materials for the posterior lamellar reconstruction.
so I've used amniotic membrane, but I've not gone in for any other alloderm like material. I have not used it. What would you, ma'am, prefer?
Yesterday there was a paper presented that silicone band was used to replace the posterior lamella.
For the support, not as a lining.
As a lining.
Silicone as a
Is
lining.
it lining?
A silicone buckle they had fashioned, cut and fashioned like that and used.
I would assume that if a silicone rubs on the ocular surface, it probably wouldn't be. They may have covered it with conjunctiva, or no.
It was covered with amniotic membrane, yes. Or it was used with the cutler beard thing. So
Maybe
that
that
Okay.
will support a lot.
Yes.
Yeah. If like if you're trying to replace just the tarsus, then I would say that that would make sense.